Hi, good evening, everybody. Can you listen to me? I can see we're already gathered together. Alex, Gali, Isa, Maria, Marine. Can you listen to me? All right, can you see the presentation? All right, I will give a couple of minutes for more people to join us, if that's okay with you. All right, we can see Moni has joined us. All right, here we go. Grace now has joined us as well. Margarita, welcome back. How you been feeling? All right, that's nice to have you back. All right, so let's begin. As usual, I will give the announcements. Does anybody need any more time to deliver this homework of arterial blood gas disorders? The limit time is due to this Sunday until almost midnight. Does anybody need more time than that? So everybody's fine then. All right, so I will talk to you about your next assignment. Your next assignment is, I will upload it on Monday. It is an article that talks about deep venous thrombosis. You will have one whole week to answer a test that will be available for you on Monday as well. That test will be available until the next Sunday, which is, I don't have my calendar right here, but let me pull it off. It'll be available until February the 3rd, so that you all be aware that you have 1 week to answer that test. All right? So let's get going. Today's subject is, we will be talking about arterial blood gas disorders. As you may all know, you already had some phase into this subject, and it's not as difficult as it may seem. First and foremost, most books and most people, they see this subject as a complicated. Some of them, they don't understand it quite well, but it is very important that you do. And you'll comprehend after this session is over that it is very easy in order for you to comprehend. But for you to do that, we need to develop an organized system that allows us to read the blood gas and acquainting that to the clinical case that we have in front of us. We will be able to comment on the partial oxygen, partial pressure in the relationship with the oxygen-inspired fraction. And therefore, we're going to be able to interpret the main disturbance as well and the relevance to the clinical case in front of us. Now, what are we measuring? We are measuring exactly these characteristics, which is the pH, the PO2, PCO2, the bicarbonate, and the base excess or deficit. So, in an acid-base balance, we already know that the pH is a system that is carefully monitored, and there's a normal range that all systems will function well and in optimized conditions, which is 7.35 to 7.45. You already know that. And in order for us to have this pH range, we need to have systems that buffer this situation, such as hemoglobin, bicarbonate, which is in the kidneys mainly, ammonium also in the kidneys, and phosphate also in the kidneys. So the main thing is that we have our blood working as a buffer to control this pH system. We have our lungs to control the CO2 that comes in and goes out. And we have our kidneys that regulate the bicarbonate that we withdraw and the bicarbonate that we throw out. So, in order for us to have this balance, we have this equation that you are very familiar with, which is the sum of free acids or hydrogens, ion hydrogens, free ion hydrogens, plus bicarbonate. They make carbonic acid, and therefore this in turn converts into water and CO2. And we do that through our lungs or through our kidneys. So this is a very simple statement. When we get too much free acid on our blood, then what comes fast and comes first is that lungs are in charge of buffering this thing out. So they will blow off CO2. So here's the number one rule. You will think of the CO2 as an acid, okay? And if we already blew out enough CO2 and we're not meeting the balance in the pH, then kidneys will take over and take place. So kidneys will get rid of the ions. So when you think about CO2, you think in terms of acid. When you think about bicarbonate, you think in terms of bases. So this is the system here. This is a 5-step approach system. First of all, you must assess the oxygenation. Number 2, you determine whether we're talking about acid or a base disorder. Number 3, we look at it if it's a respiratory component or a metabolic component, which is a step number 4. And number 5 and last, we have to come out with which comes first and which comes second, either the metabolic or the respiratory component. We're going to assess each one of them. So first of all, we have to assess oxygenation. Why is this important? Because it's not the same if we are breathing without any oxygen supply, and we are oxygenating at a rate of, let's say, 98%. That means we're fine, our lungs are fine, and I expect our pH to be just as well. But for instance, if I tell you that a patient has an oxygen saturation at 80%, and he's been having an oxygen supply with a back mask at a rate of 10 liters per minute of oxygen. Now, there's something tricky here, and you will ask yourselves, all right, if he's receiving oxygen, how come this person is not saturating enough? So I have to ask myself, all right, why is my patient hypoxic? And obviously, if he's not breathing well, if he's not breathing enough, then he will be withholding CO2. And I told you to think of CO2 as in terms of acid. Therefore, if he is not blowing off enough CO2, then he's withholding CO2. Therefore, he's withholding acids in the respiratory system. And eventually, he will develop a respiratory acidosis. We will get that further ahead. Another is that we have to, if we can, we have to measure the gradient, the AA gradient, which is the arterial alveolar gradient, and this says that the difference in concentration of oxygen between the alveoli and the artery, which in other words, it means that perhaps I do have enough air in my lungs. As you can recall, we call these the physiological shunts. There are parts of the respiratory system that are not meeting ventilation components, and the ventilation component is the blood barrier, which are the vessels, and the alveoli. But let's go back a little bit. So first, you have to see that your patient is breathing. How is he breathing? Does he have any oxygen supply? And if he does, you have to assess what oxygen supply is your patient having, because it's not the same as having just a nasal cannula, right? Or it's not the same as having a back mask with a reservoir, or is not the same as being intubated and being in mechanical ventilation. So all of these factors is the number one step to us as a patient. Number two, well, after we assess that, as you can recall in the physiology lessons, I don't know if I told you about this, but if the normal air that we breathe has a percentage of oxygen that we inspired every time we breathe in. So we call these the VO2. That means the inspired, the fraction of oxygen that it's being inspired, which is at the room air, it is 21%. Now, is there any questions so far? Is this clear? All right. When you're breathing normally, you don't breathe in 100% of oxygen, because there is no 100% of oxygen particles in the air, right? So if we take a sample of the air that we breathe, there's a percentage of oxygen molecules that are in the air that we inspire or we inhale. So the number of of the oxygen that is being inspired, the fraction of oxygen that we breathe in normally is 21%. Now, why do I tell you this? Because if you put your patient with a nasal cannula, his fraction of oxygen is going to increase, all right? It's going to increase a little bit, all right? The VO2 will increase, right? Because you're concentrating the oxygen on a cannula. Now, if you put your patient on a back mask with a reservoir, you are increasing this fraction. So you're making sure that your patient receives enough oxygen so that he can breathe in properly and to optimize his oxygen levels in the tissue. Now, is this clear? All right, let's move on. After you assess this, you check that your patient is breathing, his respiratory rate, his VO2, and his saturation level. And if he has some imbalance in the pH, you have to make your equation. Now, I'm going to switch boards. Can you see this? All right, so we have a scale, right? And right in the middle, we have our normal pH range, that it is from 735, right? 735 from 745, right? Now, whatever goes above 745, we'll call this alkalosis, right? Because it is more basic. My pH is losing acids, right? So we have alkalosis if we have a value of the pH above 745. Now, if our value of pH goes below 735, now we are on the other end and we are starting to have the opposite, which is acidosis, right? We're having acids, and we're having lots of acids, or we're losing bases, or on the other side, we're producing bases or we're losing acids. So is this clear? So that's the second step. You see your pH, and you see if it's above 745, then we're talking alkalosis. If it's below 735, we're talking acidosis. Now, all right, so if it's greater than 745, it's alkalemia, and below 735, we're talking acidemia. So acidosis is a process that causes excess of acid to be present in the blood. There's another term that is called acidemia. Acidemia is when you find out clinical issues because of the acidosis in the blood. Perhaps, let's set an example. If you find out that your pH is at 7.34, that in terms of naming the disease, that patient is in acidosis. But let's assume that the patient doesn't feel bad. He doesn't have any headaches, he's not breathing heavily, and you don't find anything anomalous in it. So you say that patient has acidosis. But when the patient starts feeling bad and you can see that he's breathing differently or has tachypnea, tachycardia, headache, and so forth, then you say that patient has acidemia. And the same goes for alkalosis. Alkalosis is just mean that That just means that has an excess base to be present in the blood. But if he starts feeling bad because of the excess of bases, then you will say it has alkalemia. So after you do that, you go into step number 3, which is you're going to see whether it comes from the respiratory system, or step number 4, you're going to see if it comes from the kidney system, either respiratory or metabolic component. And after doing that, you have to check for the PCO2. The PCO2 ranges between 35 and 45, which if you see is the same just as the pH, 7.35, 7.45, so that's about the same. If the CO2, remember, CO2, it is equal to acid. So if I go above 45, that means I am retaining CO2. And if I'm retaining CO2, I'm retaining acid. So then I will have a respiratory acidosis. And in another example, if it drops below 35, that means I'm losing CO2, all right? If I'm losing CO2, that means I'm losing acid. And what I have left are all the bases. And I will have then a respiratory alkalosis. Now, one example of these, if you all of a sudden, this is a classic example. If you see a woman that all of a sudden starts or receives some bad news or something bad happened to her, such an accident or something emotionally speaking quite traumatic, let's say that she starts breathing a lot faster than usual. Then she starts breathing very, very fast, and all of a sudden she faints. What happened is that when she started breathing a lot faster, she's starting to lose all her CO2, so her pH is starting to lower more and more and more. That means that she lost all of her acid by the respiratory system, and eventually she fell into a respiratory alkalosis and she fainted. What is the best solution to do this? If you ever see somebody like that, the treatment is quite simple. You just put a paper bag on her nose and mouth and you cover her up. So then she will start rebreathing the CO2 that she's been losing. Any questions so far? All right, so if it's not the respiratory system, if we look at the pH, and then we have nothing in the PCO2, then we have to take a look at the bicarbonate. So number 4 is we take a look at the bicarbonate, and that will tell us if that's metabolic. So the normal values, the normal range of the bicarbonate is from 20 to 26. And this is just about the same. If it falls beyond 22, that means I'm losing bases. And if I'm losing bases, I am keeping all of the acid. So I have a metabolic acidosis. Therefore, if I'm not losing any bases, if I'm keeping them within my system, that means I am accumulating all of my bases and my pH is going to go in the alkalotic. So I will have a metabolic alkalosis. So I say either respiratory or metabolic. Again, you remember from this comes from this. When you get too much, let's say, acid on your blood, you will regulate it very fast through your lungs by getting rid of the CO2. If CO2 is not working, then kidneys will take place and try to get rid of the of the acid. Okay? And final step, you're going to determine which is primary and which is secondary. So if the body starts to loosen the normal range of the pH, there are ways to compensate this. For instance, if I have a patient that, let's say his central breathing zone has been damaged of an accident and he's not breathing, then if he's not breathing properly, let's say he has a respiratory rate of about 5 per minute. So he's not breathing properly, so he's not losing the CO2 that normally he would have to. Therefore, he's accumulating the CO2, and CO2 thought in terms of acid, that means he's accumulating acid. So the other system, if the respiratory system is failing, the other system, the opposite system, the metabolic system, has to take in place, has to kick in. And what does the kidney do? Well, the kidneys start by withholding bicarbonate and exchange it from the acid. Am I making myself clear? So if we take a sample of the arterial blood gas, we will find out that the pH may be getting closer to normal ranges. The PCO2 will be highly elevated because this patient is withdrawing PCO2, but his bicarbonate will be very elevated because he's trying to compensate and to keep all the bases within because all of the acid that has been withdrawn. All right, so if the CO2 changes, we're talking about respiratory. If the bicarbonate changes, we're talking about metabolic changes. Now, the compensation comes from the opposite system. If my CO2 is getting high, all right, the kidneys will try to keep the bicarbonate and lose the hydrogen ions. If my CO2 it is being lost through a fast respiratory rate, then I have no need to withhold any bicarbonate, right? So we can say that the respiratory compensation is very rapid. That's the first one that it takes place. And metabolic compensation is not as fast as the respiratory system. For instance, when we talk about respiratory acidosis, before thinking of any disease, you have to be aware that the CO2 is high, okay? And what causes the CO2 to be high? Number one, my patient is not breathing normally. Why? Because he may have some central nervous system depression, or he has a neuromuscular disease that is not allowing the patient to breathe normally and expand the thoracic cavity, or he has a lung disease, such as chronic obstructive pulmonary obstructive disease, or it had a heart attack, or there's something wrong with the mechanical ventilation. For some reason, if I have or your patient have a respiratory acidosis, this is equal that he's with too much CO2, all right? On the other hand, if you have respiratory alkalosis, that means that your patient is breathing heavily and is losing all of the CO2. So if your patient is not receiving enough oxygen, he will start breathing a lot faster in order to try to keep as much oxygen as he can. Or acute lung conditions. This is very common. Anxiety. Fever causes tachypnea. Pregnancy, a little bit. Hepatic failure because of the pressure on the diaphragm, and some central nervous systems. So all of these have in common that the CO2 level is very low, so they fall into respiratory alkalosis. You're not seeing the presentation? I'm sorry. Now? Now? All right, I'm sorry. Are there any questions so far? All right, we were in this one. So respiratory alkalosis, the most common causes are anxiety or fever that raises the respiratory rate, such as pregnancy, hepatic failure, that is because of the diaphragm doesn't expand as normally it does. So all of these causes, we're going to find out a low level of CO2. Now, on the other hand, metabolic acidosis, we have two sides of the road. Either we are producing more acids or we are losing our bicarbonate. Now, careful with these. Diabetics, especially type 1 diabetes, they tend to form ketones, and ketones, they are consider themselves acids, so they fall into metabolic acidosis because of excess production in acids. Other one is lactic acidosis. Lactic acidosis, it comes from tissue ischemia, such as a cardiac failure or mesenteric ischemia. Yes, Cynthia? You raise your hand? No? And renal failure, that's the inability of losing acids. So if the kidney starts failing, as you can recall, it is like the filtration is failing, so it starts accumulating all of the acids. And loss of bicarbonate, we have diarrhea, we have chloride administrations, we have urethral diversion. This is a surgery where you pull out the uterus, or some medications such as diuretics that inhibit the carbonic anhydrase, and they can cause metabolic acidosis. But there's a way to find out which one is the one that is causing metabolic acidosis. And this formula comes in the test. Oh, all right, I will get to that. And when we have metabolic acidosis, either way, we're losing acids or we're gaining bases. And this is a very classical example of vomiting. We are losing all of the acids, diarrhea, diuretics. So we can fall all of these into metabolic alkalosis. So these are the normal values. The pH, 735 to 745. The VO2 ranges at a VO2 on room air at 21% between 90 and 95%. PCO2, 35 to 45. Bicarbonate, 20 to 25, 22 to 26, that's the normal range. And the base X's, The base excess or deficit, this is the amount, the approximate amount of volume that the patient has lost. And this is useful in order to specify the amount of volume that has or needs to be infused in a patient. So all of these values are ready out when you perform your blood gas work. So here goes. If my pH it is high, then I say it moved to the right of my scale. So I'm talking about alkali. So my compensation will be a low acid, right? If my PCO2 is high, I'm talking about acid, remember that, and my alkali will be low. If my bicarbonate is high, I'm saying that is alkali, therefore my acids will be low. I'm sorry. For instance, I have a pH of 7.1. This is low, so it is acid. And let's say that my patient is feeling very bad, so he has acidemia. Now I'm looking at the other values. That's step number one, well, assessing his oxygenation. Let's say he's breathing normally. Now my PCO2, it is 38. I say that's normal, all right? So I have no compensations here. I have nothing to say about this value. And my bicarbonate is 16. I say, all right, this is low, all right? So if it's low, that means my acid is the primary way. So I have a metabolic acidosis uncompensated. That means uncompensated because my PCO2 has not kicked in yet, all right? I have a normal value. Let's hit another example. My pH is 7.1. I say this is low, this is acid. My PCO2 is 53. This is very high. All right, this is very high, so that means acid. But I'm going to take a look at the bicarbonate. My bicarbonate is 26. That's within normal range. So this patient has a respiratory acidosis. And this is normal, so I say is not compensated or uncompensated. Another one, pH 756 is very high. This is alkali. My PCO2, 23, it's a bit low, right? So I'm talking alkali. I'm losing CO2. My bicarbonate is 25. This is within normal ranges. So what I have is a respiratory alkalosis uncompensated. Okay? Let's hit the next one. pH 737 is a bit normal. It is normal, right? But I take a look at my PCO2. My PCO2 is very low. All right? That means alkali, I can't say that's normal or not. I have to take a look at the other value. My bicarbonate is 14. This is very low. So I'm talking about acid. What should I do? Well, I would have to see what my patient is. For instance, he may be starting with a respiratory alkalosis that it has been already compensated, or he started to have a metabolic acidosis and he compensated with a respiratory system. Either way, I have to take a look at the patient. Another one, my pH is 740. That's normal. That's normal. My PCO2 is 58. This is high. I'm talking about acid. But my bicarbonate is also high. All right? So I'm talking alkali. Now, which is which? You're not going to be able to answer this unless you take a look at your patient, because it can be either somebody that wasn't breathing and the bicarbonate starting to buffer this out, or somebody had diarrhea and he started to compensate it, like withholding the CO2. So either we're talking a respiratory acidosis, which has already been compensated by a metabolic component, or a metabolic alkalosis that had been compensated by the respiratory component. Is there any questions? All right. Let's take a look at this. The pH is 721. I said this is low. This is acid. My PCO2 is 52. This is high. This is acid. But my bicarbonate is 32, which is high. So I say in this case, it can be a respiratory acidosis decompensated. Decompensated, that means that, let's say this clinical case. I have a woman who's 88 years old, and she arrived at the emergency department for having a chronic obstructive pulmonary disease. She's not breathing, and we had to intubate her because she was her oxygen saturation was 60%. So we have to start her on mechanical ventilation, assisted mechanical ventilation. So we take a blood sample and we pull this off. So I say in this clinical case, her primary condition is from her respiratory system. So she's starting withholding the CO2. So she has a respiratory acidosis. What happened in the kidney? The kidney tried to withhold as much bases as possible, as much bicarbonate as possible, but guess what? It held the maximum bicarbonate and my pH still acidotic. In this case, I say it is a respiratory acidosis decompensated. Decompensated when my buffer system acted and my pH value remained the same. Questions up here? No? But then again, you have to look at the clinical scenario. If you don't look at the clinical scenario, it'll be tough that you make a diagnosis just based on the gas blood work. Now, let's hit the next one. Now, you already said to specify which disease you're talking about, either acid or base disorders. I have a question here. So when it will be a compensated respiratory acidosis, all right, I'm going to go back a little bit. If I said, let's assume that I have these same values, but I have my pH on 36. Now I have a normal pH, but my other values are already rearranged. So I saw my patient. I know that she had been on a respiratory acidosis, but now she returned. This retaining of bicarbonate made her pH to go back to normal values. In this case, I was talking about respiratory acidosis compensated. Is this clear? All right. So you already said what you have to do is first look at your oxygen status, check out for your pH values, take a look at the CO2, then bicarbonate, and then you take a look at your patient and decide which is first. Now you can have both sometimes. Sometimes it gets a little tricky, but it doesn't have to be. If you follow this methodic system as a 5-step approach, you're not going to be lost in the way, okay? Well, these are some examples. Okay, Margarita, you say what is primary? In this case, I'm going to go back again. In this case, that I told you that it is an 88-year-old woman with a chronic obstructive pulmonary disease, you already know that the primary component is respiratory. Therefore, you conclude that the respiratory acidosis is the primary disorder that had been compensated with a metabolic component. That is the way that you define which goes first. You take a look at your patient. All right, so when we have a respiratory failure, such as in the case I just told you about, then we will be encountering a uncompensated respiratory acidosis. Now, there are some people that over the time, they get used to having a great amount of CO2, but they switch the system to be chronic compensated. So in this kind of patients, you will have the respiratory component as a primary, but you will see the bicarbonate making its action, and the patient is fine. So we're talking about compensated when the pH is within normal ranges. Now let's assume that this patient didn't take his medication and falls again into a respiratory crisis. Then we're talking decompensated when the pH falls back again. So that patient is withholding CO2, so the pH falls again, and this is quite common, especially in the chronic obstructive pulmonary disease. Now, final step, when you have an acidotic patient, I told you, you have to weigh either he's producing more acid or he's losing a lot of bases. So this comes on your final exam, and you have to determine the anion gap. The anion gap is the difference between the measured positive ions and the negative ions in the plasma system. So we do this simple math equation, and the value will tell us if my patient is producing a lot of acids or if my patient is losing a lot of bases. And that goes like this. It is the sum of the sodium plus the potassium minus the chloride plus the bicarbonate. These are negatives and these are positives. This is a simple equation for anion gap. And the normal range for anion gap is between 10 to 18. If I have a normal anion gap, automatically my metabolic acidosis, the origin is that I'm losing bases. If I have an elevated anion gap, that means that my patient is producing a lot of acids. Again, normal, and I have metabolic acidosis, is loss of my bases, okay? High anion gap, it means that I'm producing a lot of hydrogen ions, okay? So with a high or an increased anion gap, that means I'm producing a lot of acids, And this is very common on lactic acidosis, ketoacidosis, or an overdose of aspirins, or careful with these on diabetic patients that hadn't been controlled and they fall into kidney failure because they're withholding all of the hydrogen ions. And if I have a normal anion gap, that means I am losing my bicarbonate, and that means on diarrhea, chloride administrations, or diuretic administrations. But the most common cause, diarrhea, because you're losing all of your bicarbonate. And this is very important because the way you treat one from the other, it varies widely. What would you do to a patient that is been with type 1 diabetes and arrives into a uncompensated metabolic acidosis? What would you do? Well, you don't have to know this, but you give him insulin because the lack of insulin is raising his glucose and switching from the metabolic pathway to gluconeogenesis. So you're stopping that. You have to stop the gluconeogenesis in order for you to stop the production of ketone bodies. Now, you do this differently in a patient that had been on diarrhea. If your patient has diarrhea, first, you have to stop the diarrhea. Second, you need to hydrate your patient. So the treatment is very different. And you have those patients with metabolic acidosis. But when you have this, you have to check out for the anion gap. Any questions? So, causes of high anion gap is this Amut piles. Amut piles, this is the technique to learn it, which is alcohol. Methanol causes blindness. Uremia, this is in kidney failure. Diabetic, because of the ketone bodies. Paraquat, this is a very nasty poison that uses as a herbicide in the crop fields. Infection, which is the common cause. Careful with this one. You have to assume that every patient with diabetes, it is infected. It is infected until confirmed otherwise. I'm going to say this again because this is very useful for your clinical practice. If you see a diabetic patient that comes in with metabolic acidosis, you have to assume that this patient is infected until proven otherwise. Now the other cause, it is lactic acid production because we switch into the anaerobic respiration and tissue necrosis, such as mesenteric ischemia or myocardial infarction. Ethylene glycol, this is in terms of people that try to make suicide with antifreezers, and also taking a lot of aspirins. A normal anion gap, first and foremost, diarrhea or some form of therapy with diuretics, or in you're not going to see this. This is high output fistulas. Fistulas are a pathway of two cavities with an epithelialized pathway that wasn't there. For example, a pathway between small intestine to the skin. You can have metabolic acidosis because of loss of bicarbonate. Any questions? No, Danny, you just performed that in metabolic acidosis. All right, are there any other questions? All right, Alex, how do you treat a metabolic acidosis? You treat the cause, the main cause. So if your patient is, let's say he had diarrhea, you have to stop the diarrhea and hydrate him. And in that, the pH will return as normal. If your patient started on on diuretics, well, you stop the diuretic and you infuse an IV solution. If he has a fistula, you have to replace the volume that has been lost. You don't give bicarbonate because that's not the root cause. You don't give bicarbonate unless the only indication to infuse bicarbonate on a patient is that your patient has a pH of 7.8. All right? Never give bicarbonate because that's not attacking the root cause. So you have to attack the main cause. You have to address the origin of the metabolic disorder, and then it'll correct eventually. You do not give bicarbonate. The only time you give bicarbonate is in an effort to stop your patient from dying, because if you find out a pH of 6.7 or 6.8, that means that your patient is severely ill, and in an attempt to do that, you infuse bicarbonate. Otherwise, you don't. Any questions? All right, Margarita, about the clinical cases. Yes, I would like you, after this class, I would like you to tell me if it's compensated or uncompensated. Danny, it says, why 7.8? 6.8. If you find out you have a metabolic acidosis at a range of 6.8, that's the only indication to use bicarbonate. Any other questions? Sorry, I meant 6.8. 6.8 or 6.7, that's the only indication. All right, I thank you all for being in here. I really thank you for being present on a Friday night. If you're gonna drink, don't drive, please. Enjoy your weekend. And I'll see you next week, all right? Thank you. Bye-bye.